Thank you so much. It's such a pleasure to be here. I want to give a quick thanks to Horizons, especially Kevin, who's made all of this possible all these years, and to our really good friends at the Cohen Foundation, who've worked with Healing Breakthrough from the very beginning. So this is a little bit of a fruition of a dream that you're witnessing from me. When we came together to form Healing Breakthrough as a public charity several years ago, it was with the vision that the Veterans Administration would bring these very, very powerful treatments to the veteran population. And we knew that if that were ever to happen, we would need a real champion. And that person would have to be bold, and they would have to be smart, and they would have to be articulate, and they would have to be someone who could really see both the medical and clinical utility of this, but also have the heart to know that we need this in the veteran community. And so it's with incredible pleasure that I'm introducing, for the first time on the Horizon stage, Undersecretary Elnahal. The Undersecretary is the head of the largest integrated health system in the United States, which is the Veterans Administration. So thank you so much, Undersecretary, for joining us.
Appreciate it, Jason.
Absolutely. I really appreciate this. So we've had a pleasure at Healing Breakthrough over the past few years working with some of the very best clinicians and researchers in the world. But it turned out, as we started working in PTSD, the vast majority of them are VA clinicians and VA scientists. You have an amazing team. Could you speak to what PTSD means in the VA and what you guys are doing?
Yeah. So first of all, I want to thank the Horizons organizers, Jason, for you having me on stage. I was wondering who you were talking about when you said, smart, articulate. But here's the reality. The reason I'm here is that the data and the results and the stories that I've heard from veterans who've gone through these studies and have gone through these therapies speak for themselves. My charter, my mandate, the reason that I'm in this job is to do the very best that we possibly can to help veterans, including the veterans in the most vulnerable situations and with the most severe conditions in mental health and otherwise. And here's the reality. For conditions like PTSD, and in particular the unique manifestations of PTSD that we see among veterans, the evidence-based therapies that we have, while they help, pale in comparison if we are able to replicate and scale the preliminary results we have seen in the studies for psychedelics, especially MDMA for PTSD, and increasingly psilocybin for treatment-resistant depression. And so that is the reason I am here. And I was really touched to learn that some of you have been at this since the mid-1980s, when I'm sure nobody like me would ever be on a stage like this talking about this. So I think the folks who have been at this for decades we should just give them a round of applause. And you're right, Jason, we do have an incredibly awesome team. We have physician scientists like Dr. Rachel Yehuda. Rachel, can you raise your hand if you're in the audience? There you are. Oh, great to see you. I had a chance with the secretary to meet one of the patients that went through her trials. And every single story you hear from veterans who've gone through this is so touching. You never forget it. I'll just talk about one story, and I think you know him. The vast majority of you know him, Jonathan Lubecki. This is just an incredible person. What a patriot. Served twice in the armed forces. First as a Marine in the 1990s, and then after 9/11 happens, when he saw the towers fall, he joined the North Carolina National Guard and was deployed to Iraq. And when he describes how his PTSD manifested, ending multiple relationships, including a marriage, not being able to function, having hyperarousal symptoms, every single day for the majority of every day that he lived. And then trusting us with his care at the VA and following through with his care, not making as much progress as he would have liked and we would have liked. Remember, our clinicians live to help veterans, and we have been frustrated for so many years for how severe these conditions are and what the existing therapies can do and not do. It actually took an intern, a medical resident, to slip him a piece of paper and say, hey, go to this MAPS trial. And he said, don't open it while you're here, because he was deathly afraid of being kicked out of his program. And I had a chance after doing a podcast with him I brought him into my office. I have this office for however the hell long I have it, and we have a great view of the White House, et cetera. And then he decided to pull out his phone and show me a video of him on the battlefield in Ukraine. So he's one of those incredible people that went to Ukraine because he knows a thing or two about fighting war to assist Ukrainian forces. He was on the battlefield. The sounds and the visible active battle were very evident. The guy was not fazed at all. And I said, if you had done this right after you came home from your second experience in the military, could you have ever been able to tolerate this? And he said, I would have completely passed out. I would have completely broken down had it not been for this experience. So that's why I'm here. I'm here to try and elucidate even more of the benefits of these therapies. And the good news is we have an incredible workforce and some of the leading academic scientists who are going to help us do it.
Thank you so much. And John's story is an incredible one. Many of us are friends with John, as I am. And there's so many veterans who share his story and need this. And one of the things we were talking about, which you mentioned, was there's just nothing like this. When we look at the treatment of PTSD, we have things to offer veterans, but they're not good enough. And so here we are.
I think that's right. And what we need to do as a broader scientific community, but especially within the VA, is prove the case further for two reasons. The first is that veterans obviously carry their own unique manifestations of diseases that anybody can get. Obviously, PTSD, major depression, intractable anxiety, a lot of the things that we're concerned about on mental health. But also, they tend to be sicker with comorbidities because of the trauma they experienced in war, but also the average age of the veteran population is higher than the general population. And so we know that the combination of these conditions can make experiences with therapies different for veterans, which is why for the first time, the VA is funding clinical trials on MDMA and psilocybin. Now, we know that the way these therapies have been studied for a lot of good reasons. Some of the initial clinical trials, you want to prove the effect size, you want to pick the right patients. They tend to be smaller studies. There is veteran representation, but we need much more robust veteran representation in these cohorts, which is why we want to fund multi-site trials. We have about 13 studies happening right now, and we want to expand them further and prove the case for veterans. The second reason is that we think with our resources and with our incredible workforce who's doing this research, we can start to answer some of the questions that the broader clinical and scientific community has on some of these really novel therapies. For example, do you actually need 8 hours every 3 sessions for an MDMA therapy? And do you actually need 2 clinicians per patient for that duration? Anybody who's run a health system or clinical outfit knows that that's a very resource-intensive endeavor. And we know that the moment the FDA approves MDMA, I don't have any insight into that, so just to preface any question, we're going to see demand for this go through the roof, especially among the veteran population. And so one of the key questions is, do you actually need 8 hours? Can you do it in 4 hours? Can you do this type of therapy in group settings? We know that group settings are often extremely beneficial for veterans, not only because the therapy is easier to administer overall, you reach more veterans, but veterans love being around other veterans who know that they have a shared experience, and it's therapeutic inherently to be among a cohort who understands what you're going through. So imagine adding psychedelic-assisted psychotherapy in a group setting, what the benefit of that could possibly be. And we can better elucidate things like dosing, some of the nuts and bolts, the sausage making that we have to think about as clinicians every day for any type of therapy. So the idea is, how do you improve the effect even more, but also how do you improve how to make this an easier therapy to administer at scale so that the most people have access to it as possible?
Thank you. So a lot of people here don't know that last year in September, you called for a state-of-the-art conference at the VA. Could you tell us a little bit about that, what that means to the VA and what you learned?
Yeah, we had every physician, clinician, scientist, and basic scientist in the system get together at a conference in Colorado. That was one of the most interesting scientific conferences I've ever been. I mean, the people are awesome. But, you know, so many interesting, not just scientific debates, but ethical debates, right? So I just remember one of our scientists, I'm not going to put him on the spot, but he stood up and made a point about, again, the difference between what's already approved, what is in the evidence-based list of therapies now, and what he was seeing in his research. And he challenged us to say, why aren't we scaling this immediately as an ethical matter? Because the potential of this is so much better than what we have now. And, you know, just imagine that this is the type of conversation we have now. Vice 10 years ago, 20 years ago, again, the heroes that started this in the 80s. You know, we're now talking about the ethics of not doing this and how that might be an ethically problematic scenario. So that was really interesting, but also just getting the minds together and just witnessing part of that conference was really just so empowering for me just to understand if there's an organization in the United States who can do this work at scale, who can do this work effectively for the most deserving and awesome patients in the country, the people who've worn the uniform and served our country, it's actually the VA. And the reason it's the VA is because all of the people in that room at that conference. So make no mistake, when we start funding these studies, insights will be consumed by the entire American healthcare community because we're asking the questions that I think people in the mental health space have been asking for years, and we're going to get to those answers sooner rather than later.
That's fantastic. So, of course, the VA is a federal agency, and some people don't know it's the second largest federal agency, second only to the DoD. And of course, you have close relationships with the Veteran Affairs Committees and Congress. Can you speak to why that's important, why political support is important, and what you're seeing in the Congress right now?
Yeah. So, Constitution, Article 1 is Congress, not the president, not the executive branch, certainly not the VA, right? So we can't do anything unless Congress authorizes us to do it. And we also can't do anything in terms of funding and resources without Congress appropriating that funding. And so everything on our agenda depends on congressional support. And you might think that an issue like this would be controversial among members of Congress on our committee. I actually think one of the things that was most surprising to me when first learning about these endeavors and interacting with Congress about it, strong bipartisan support, especially for research in these areas. We have members of Congress, people like Morgan Luttrell, who represents a pretty conservative district in the state of Texas. Doesn't agree with the president all that much. If you look at his Twitter account, that'll be immediately evident to you. And so obviously he's my boss. Nonetheless, he has been the biggest supporter, by far, of the work we're doing on this, because as a veteran himself, he served this country honorably as a Navy SEAL. He came home, did not find the medical establishment offering anything that worked for his post-traumatic stress disorder and his mental health conditions, and did many of what your patients and your study subjects had done before, which is to seek this type of therapy out in more traditional settings. You know, American Indian, Alaska Native cultures have psychedelics as part of their culture. He did ayahuasca, he did, ibogaine and a couple of other things, and he told me that changed his life. So he's been pushing for this since he's been a member of Congress, and the fact that we're trying to lead on this at the VA, I think, was meaningful to him, and so he's a big supporter. Let's add to the list of other folks on the other side of the aisle, the president, Congressman Van Orden from Wisconsin, huge supporter of this. Congressman Jack Bergman, General Bergman, represents the Upper Peninsula of Michigan. He's a big supporter of this, and a number of Democrats as well. And so, especially on the House committee, but also increasingly in the Senate, they want us to do this type of work, and they've been trying to be proactive to pass even more legislation to enable us. The good news is, at baseline, the DEA has a much easier waiver process to be able to do studies on psychedelics than, for example, they do for cannabis even. And cannabis has been advocated for more aggressively by the veteran community for some time, but I think psychedelics has since surpassed that in terms of acceptance and bipartisan support from Congress. So we need to make sure that that is continued. You know, that's not a guarantee. And that means conducting these studies ethically, conducting these studies with the utmost and highest scientific rigor. I'm already seeing that type of discipline with some of the talks I've heard so far this morning. And that's not just us, that's the entire scientific community that just has to do this work diligently, do it right, and keep to the clinical care mission of what we are doing. And I think as long as we do that, that bipartisan support will only get stronger.
Thank you for that. And it has been remarkable. There's very few issues, I think, in this political climate that you could really say are truly bipartisan. But the overwhelming need to take care of veterans, I think, crosses the aisle in almost every way. And so we're so pleased that you have such great relationships with members of Congress, and like yourself, we're incredibly pleased that that our elected officials on both sides of the aisle are supporting this. So along that same thread, there are a number of people here who are veteran voices and have spent most of their time, and I could call out Jesse Gould at Heroic Hearts, Juliana Mercer, who works with us. How important is the veteran voice?
The veteran voice is absolutely essential. The way that you tell this story has to be through the voice of veterans telling the story. Dr. Yehuda, when she showed me what her study was about, of course she had the data up on the slides, which is just incredible data as we've seen in trial after trial. But she led with a veteran telling his personal story, having gone through that trial. So the power of combining the data and the results at scale with the population of veterans that we're serving, with veterans who tell the before-after story of their experience with post-traumatic stress, their experience with depression. And again, these are people who deserve the best life after they come home after they serve. And so many examples of people who come home with trauma and don't necessarily find the care they need and the solutions they need, to the point where they end up homeless, or the point where they end up attempting suicide. You all know Jonathan's story. He's told it many times. He attempted suicide 5 times before he was introduced to this clinical trial. And then after he went through the clinical trial, he never used, and still to this day says he never used MDMA ever again. So we talk about the benefit profile. Compare that to the risk profile. The risk profile is actually better than the vast majority of things that we give to patients for mental health conditions that are already FDA approved and part of evidence-based clinical practice. And so that power of the data and veteran stories, that's an unstoppable narrative. Again, as long as we do work to generate the data that is responsible, ethical, and that we don't hurt our patients and find ourselves in a place where we're on the defensive back foot when it comes to this work. I think that's the biggest risk that we all face as a scientific and clinical community. As long as we're on the up and up there, story after story with veterans will just prove the case in and of itself.
Thank you for that. So with the kind of congressional support you saw in 2023 and the support of the administration, obviously, you didn't hesitate to act. Can you expand a little bit about the RFP that came out from the VA in January?
Yeah, we intend to fund at least in the millions of dollars, if not more, larger clinical trials to investigate some of these questions that I talked about earlier. So do you actually need the 8-hour sessions? Can you do them in shorter sessions? Can you do group therapy sessions? Can you more efficiently administer the therapy with a shorter course of therapy so that next patient in line can get in? How do you ultimately understand how to dose and what the pharmacokinetics are of these drugs so that we can just refine and optimize how we distribute and ultimately use them clinically. These are things that, again, VA being the largest integrated healthcare system in the country, and by the way, having affiliations with almost every academic medical school in the country, is really important. We graduate 70% of physicians in the United States having had some experience in their training in the VA. We graduate half of all types of mental health professionals overall, not just physicians. Psychologists, behavioral health nurse practitioners, behavioral health social workers, and the list goes on. Half of that entire denominator of mental health clinicians train at some point in their training experience within the VA. So we have more mental health clinicians in the country than any other health system. And I would argue we have the best mental health clinicians because that is what veterans demand after their service. So I think we are an organization that can directly conduct the best research on this, and if not directly conduct, catalyze through our extensive affiliations with the academic medical schools, physicians, physician scientists, clinicians in the country. We can catalyze the best and most effective research on this. So that is what this is supposed to do. It's supposed to be the beginning. This initial request for proposal is supposed to be the spark that yields even more research, expand after MDMA and psilocybin into that long list we saw in the previous presentation of other types of psychedelics. Chances are, because of the similar mechanisms of action, similar effect areas in the brain, you can see unique benefits of some of these other compounds. We're proving the case that the federal government is no longer afraid to engage in this. It took some work to get there and some advocacy internally, trust me, but we're there. And so this is a spark that I think will lead to even better research and more robust scaled research into the future.
It's magnificent. So it's worth pointing out you didn't stop there. So you formed a task force at the VA to directly coordinate, bring people together on a national level. I believe they're called IPTs.
Yes.
Could you speak to that as well?
Yep. That's the inside baseball acronym for an integrated project team, which is a multidisciplinary team that includes not only our research experts, who are the subject matter experts for the whole endeavor, but also our operators, our administrative operations, our clinical leaders, our medical center senior leadership, so our directors, our network directors, equivalent to CEOs and system CEOs, involved in a multidisciplinary group to prepare for beginning to administer this therapy as soon as the FDA approves MDMA. You're all aware of the awesome, groundbreaking research that MAPS has done that led us to the point where they were able to submit their clinical trials, their phase 3 trials to the FDA for consideration for possible approval. That approval could come as soon as later this calendar year. Again, I do not know when that will happen or if that will happen. But if it does happen, we have to be prepared, especially the VA has to be prepared to respond to the overwhelming demand that I predict we will get from the veteran community. And I know this because some of the folks in this room aren't just scientists in the civilian sector doing this work. You've got a lot of veterans in this room. You've got veteran service organizations with really awesome, progressive subunits like Disabled American Veterans, an incredible organization with whom we work on so many veteran priorities. They're saying we need to do more of this work, and they're looking to VA, but also any other possible option that veterans will have to get access to this therapy. But the moment it's approved and the moment we start to see MDMA manufactured and distributed at scale, veterans are going to be demanding this from us. And it's my responsibility to make sure, even as we start to disperse the dollars on this RFP as of August, which is our target date, you know, if the approval comes only a few months after that, we've got to be ready. We've got to be operationally ready to start. And so that's why we started a couple months ago to put this team together, start with our centers of excellence, and then set up the infrastructure. I would not underestimate, when it comes to the actual business of delivering this therapy, the preparation and the investment health systems and providers will have to make. You got to have the space, you got to have the clinicians, you got to have the time of your clinicians scheduled and ready to go. I predict that you will see a proliferation of providers who specialize in this, because when you have a dynamic, I know this because I've ran health systems before, where any space you give to one type of service, is a space you're not giving to a different type of service that may generate more revenue, that may need to meet demand of patients writ large in your community. There may not be enough capacity in our traditional brick and mortar hospital systems to be able to deliver this therapy. So I predict that there will be a proliferation of very unique and specific providers, and I know there's already investment into that concept happening across the country. That'll be an important thing to look for. But what I refuse to do is to completely outsource that work to any other party. The VA has to be on first, as we have been with the mental health mission, when it comes to the entire scope of what the mental health needs are of veterans. And so that's why I want us to be ranked among those specialist providers in administering this therapy once the FDA approves it.
That's fantastic. So one of the things that the VA is, as you said, the largest integrated health system in the nation. You have everything from complicated big city, multi-center hospitals and medical complexes to the tiniest, rural clinic where you're serving veterans. Like how important is it to the VA that they're able to deliver care over all of those settings?
It's extremely important, Jason. Obviously, the initial investments, the CapEx that go into new and exciting types of therapies, the infrastructure needed inevitably start in urban areas where the resources are and where the population is. We have an overrepresentation of veterans, for example, in American Indian and Alaska veteran communities, Alaska Native veteran communities. Indian country is the highest serving demographic in the US military by far of any other demographic. Imagine that, despite the historical marginalization that community has experienced in this country. Somehow they are the most patriotic group that we have, and they deserve the best, and they deserve, by definition, access to this therapy once it becomes available. On top of that, we have overall breakdown in this country has been 20 to 25% of the population lives in rural and highly rural areas. We have a much higher representation of veterans who choose to live in rural areas. A lot of veterans came from those areas asymmetrically because the military tends to recruit, in many cases, from areas that are more economically vulnerable. All rural areas, by definition, are more economically vulnerable than urban areas. But also a lot of veterans just prefer living in those types of environments. And so, we have a mandate to deliver our benefits and care to all veterans, wherever they are. And so the fact that we have more clinics, more infrastructure in rural areas than any other health system on average in the country is important, because we need to prove the case where our centers of excellence are right now. And then our system always involves a market that inevitably includes at least a couple of clinics in these types of rural areas. When this therapy is available and when we prove the case that it works, and when we figure out how to streamline and make the delivery more efficient, we have to bring this therapy to our rural areas. And we're best able to do that as a system because that's where veterans live. And so where we can do that for veterans, that's the most important mission, and where we can teach the broader American healthcare system how to do the same is also really important. I'll just give one example in a different area, but highly analogous to your question. We have a lot of veterans with cancer who live in rural areas who require infusion therapy. Again, asymmetrically, infusion centers of all types are closer to urban areas. We bring our infusion teams and all of their equipment to rural CBOCs through, which is our acronym for clinics, a community-based outpatient center. We bring those infusion centers 1 day a week, 2 days a week to rural veterans so that they don't have to drive 2, 3, 4 hours to come to our academic medical center affiliated hospital. And that's been really important because it's reduced the number of veterans we've had to send out into the community, into the private sector for care. But it's also made that care more accessible and more effective. And the no-show rate has gone down with that program we call Closer to Me. I imagine that something like this can also be analogous for when we have expert teams, again, who will be overwhelmingly in urban centers. They can go out once we prove the case with the evidence and deliver it closer to the veteran so that it's more convenient and they're more likely to follow through with it. And we're really excited about that prospect.
That's fantastic. And you touched on something, and I think this is worth ending on. A lot of people might have a stereotype of a veteran. You're kind of a random white guy like me. But that's not the case. Veterans are of every race, every gender, and identity. their sons, daughters, mothers, fathers, cousins to every community in the United States. And I know the VA takes a lot of pride in the diversity of the patient population that they serve.
Yeah, I mean, look, Jason, every single veteran matters to us, and that includes you. We hope that you consider being a customer of ours. But, you know, it does end up being the case for a lot of the reasons I mentioned before about asymmetric recruitment of vulnerable communities into the military. The veteran population happens to be among the most diverse group I've ever encountered in healthcare. You know, upwards of more than 20% of our veterans are African Americans. Similar percentage are Latino. We've got an overrepresentation of Jewish veterans. We've got an overrepresentation of veterans of color of all types, LGBTQ plus community. And that really just makes the veteran community even more awesome than you would already think, just because they wore the uniform in the first place. And so we are constantly trying to prove the case on how to close disparities and gaps in care. A dynamic that you often see with new and innovative therapies is that they asymmetrically go to populations that have more means, and you immediately start to see this dynamic of a disparity. So that's why the VA investing in this, by the way, the same benefits and access to care for all veterans, regardless of their demographic group. We can prove the case that for the first time, a new and innovative therapy does not have that disparity associated with it that we're measuring a year or 2 years later. And that requires us to get into every single community where people are and deliver this type of therapy. And so we're very focused on that, and I think VA is uniquely poised to be able to do that.
It's such an amazing thing that you've decided to take a leadership position in this field. It's heartwarming. Like I said, it's the fruition of a vision of mine. Thank you so much for all the things that you're doing and are continuing to do, and your vision and your heart, which I think we can all agree is just unbelievable to hear. Could you finish by asking or expanding on the idea of what could we do for you?
Well, look, I started by saying that I'm here because the potential, the data, the science, and most importantly for me, the veteran stories speak for themselves. I just want to make clear that, you know, I might come into this job with a more progressive view on some of this stuff than others, but I wouldn't be able to be up here if it had not been for the decades of work that the people in this audience have done. I am in the business of doing what works for veterans, and the degree to which this area of work is so promising for veterans, that's the reason I'm up here. And so I'm on a pedestal that is built upon bricks that you all have laid for many, many years. And so I want to express my appreciation for that. My only request is for you to keep going, because if you keep going, we keep proving the science, we keep surprising the folks who are skeptical, and appropriately so. Everyone should be skeptical in science. That's part of the culture we have in science. But the more you continue to prove the case on this, and the more you help us set up the case for veterans, the easier the VA will be able to take this and run with it to improve veterans' lives across the country. So thank you.